Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
Well, hopefully, Tracy, you've never had a migraine headache?
I think maybe one
You
or
have?
two, yes.
Recently?
No, I got divorced. Sorry.
Well, I'm glad that worked for you. Maybe you don't need to listen that closely
It was
to
a long
today's
time
program,
ago.
but you should anyway.
Right.
One thing about it is you are not alone. The National Headache Foundation estimates that nearly 12% of the population have migraine headaches. That's nearly 40 million people. And women, like you, are about 3 times more likely to have migraines than are men. Migraine headaches can cause significant pain for hours, even days, and they can be so severe that they're disabling.
There's a long list of drugs that may help to treat a migraine once it occurs or reduce the chances of having one. But most of these drugs were designed to treat other problems like depression, seizures, or heart disease, with a side benefit sometimes of also helping migraines. All that is about to change. We're finally seeing treatments devised specifically to prevent migraines. Let's talk with a Mayo Clinic expert. With us today is neurologist and division chair of neurology education at Mayo Clinic, Dr. Chris Boes. Welcome to the program, Dr. Boes. It's nice to meet you.
Thank you. Nice to meet you, too.
Dr. Boes, thanks for being here. I would bet that there are a lot of people in this country that are glad to hear that finally there are some drugs that are designed to actually prevent migraine headaches, specifically prevent migraine headaches.
Yeah. So this is an exciting development. There was a preventive many, many years ago called methotrexate that was developed based on the pathophysiology of migraine. Unfortunately, it had severe side effects, and so it's no longer available. So this development is really nice. Like you said, all the prior preventives, they kind of were chosen in this fashion. A patient with migraine and, let's say, high blood pressure would be on a medicine like a beta blocker. The patient would report to their doctor, my blood pressure is better, but boy, my migraines are better. So then the drug company that would make the beta blocker would say, well, let's study that in migraine patients who don't have high blood pressure. And they would study them versus like a sugar pill, a placebo, and if it showed a response, then it would become part of a practice. So it's really an exciting time because I think finally patients have a feeling that we're investigating the underlying pathophysiology or cause of their migraine, and that this treatment is specific, for their underlying etiology or cause of their migraines.
What took so long to get here?
Well, it's interesting. This class of drugs, it was based on research done where they find elevated levels in the blood of a molecule called calcitonin gene-related peptide, CGRP, and that's been known since the 80s. So when I did my headache fellowship, I did it in England with one of the folks who first did research on this topic. So they knew about this, but it just took a long time. First, they attacked that molecule with a pill, pardon me, and they're still doing that. But unfortunately, the first round of drugs had liver toxicity as a side effect, so that didn't go very far. So then what's happened over time as they try to create medications that basically work against CGRP, they found the current class, which is basically a special antibody they've created against either CGRP, which is a molecule, so it's kind of like the key, or there's antibodies against the CGRP receptor where the molecule works, and that's kind of like the lock. So you can have antibodies against either CGRP itself, so antibodies against the key, or one antibody commercially available against the lock.
So these, what you've figured out is that this CGRP, which is, did you say is a protein or a peptide?
Yeah, it's a peptide. Yeah,
and that's what triggers a migraine?
It's interesting. CGRP is involved in numerous systems in the brain, peripheral nervous system, heart, skin, pancreas, kind of all over the body. But what the basic research started off by saying, we're going to measure in the blood what happens to CGRP when you have a migraine. It goes up. When the migraine is treated, let's say with a medicine like sumatriptan or Imitrex, it goes down. So then they said, well, maybe we should try to manipulate that system since it's a marker of the migraine itself. So that's kind of where they decided to try to find different medicines that would affect that specific mechanism.
Is it CGRP that makes a difference if it's a migraine or just a regular headache?
Yeah, it's interesting. So Not necessarily. So CGRP is elevated in other kinds of headache, like cluster headache. It seems to be a marker of, to feel pain, your trigeminal nerve, which, controls sensation from your face and kind of your forehead, needs to be activated in some way. So CGRP is released into the blood when that trigeminal nerve is activated. So I see lots of patients with cluster headache and migraine. It is not a clinically useful test right now, but it is, when they measure it, they find that. So yeah, it's a very exciting time.
So these drugs, how many are available, and are some more effective than others, and are they FDA approved?
So it's interesting. So there are 3 FDA-approved CGRP monoclonal antibodies now. So one of them is against the receptor. That one's called Erenumab or Aimovig. 2 of them are against the key or the molecule itself. So that's Fremanezumab, which is Ajovy, and Galcanezumab, which is Emgality. So there are 3 of them commercially available. One was approved in May 2018 or so, and the other was later in September. There's another one that will be coming online, I suspect. I mean, I don't work for the FDA, but it'll probably be coming out in this year, most likely. That one's given intravenously, so that will have its own set of problems.
And the other one's given orally?
The others are given by shots, under the skin injections, and they're either given monthly, which is the most common treatment, or quarterly. So they have a very long, they last a long time in your body. So that's one of the benefits as compared to typical preventive medicine. So in migraine, there's sort of, everybody has to have something to take when you get a migraine. That's called acute treatment, but you also need a preventive treatment if your headaches are quite frequent, let's say a couple times a week. Then the preventive, the benefits start to outweigh the risks. So, so it's really nice, to take one injection a month versus a pill. And some of my preventives you have to take 2-3 times a day.
Are there any side effects?
Yeah. So, every treatment has a little bit of poison in it, right? So it's remarkable, though, with this class of drugs that they work about as well as the quote-unquote old preventives. About half of the people have a 50% reduction in how frequent they have migraines, but they have pretty markedly fewer side effects. And, some of them, like with Erenumab, some people get a little constipation. People can get, because these are injections, they can get some injection site reactions, like in your thigh or your arm where you inject them. But, sometimes I sort of evaluate a medicine by how many phone calls I get from the patients, and I just don't get a lot of phone calls on these medicines. The main phone calls have to do with getting it covered by insurance. It's expensive, so these are out of pocket about $6,900 a year, which is a pricey number.
How can insurance not cover this?
Well, life is complicated, so most of the insurance companies have sort of fallen into this sort of practice where you have to fail a couple of the older oral ones, which is not unreasonable since, again, these new ones work just about as well as they did. Those are, in some cases, super cheap. Propranolol, which is an old migraine preventive, is very inexpensive. So, and it depends. So private payer insurance versus if you're on Medicare or Medicaid versus if you're self-paid. There are different ways, though. I will say that I've been able to get, in all those different sort of situations, I've been able to get the medication coverage covered by different either safety net programs or programs through the pharmaceutical industry or others.
Oh, that all sounds good. So finally, some really good news for migraine sufferers. New drugs designed specifically to prevent migraine headaches. We've been talking with neurologist and the Division Chair of Neurology Education at Mayo Clinic, headache expert, Dr. Chris Boes. Dr. Boes, thanks so much for being with us.
Thank you.